30 seconds or so. We have a lot of people that are still logging in, but we'll get started shortly. Thank you for being patient. Okay, we want to be respectful of everybody's time, so we're going to go ahead and get started. First of all, I want to say hello to everyone. My name is Deborah Kilstein. I'm Vice President of Quality Management and Operational Support at the Association for Community Affiliated Plans, or ACAP for short. I want to welcome you to today's webinar on health centers and managed care organizations working together to meet the healthcare needs of those experiencing homelessness. This webinar is being presented jointly by ACAP and the National Healthcare for the Homeless Council. Before we get started, I wanted to tell you a little bit about ACAP. Our mission is to strengthen not-for-profit safety net health plans in their work to improve the health of lower income and vulnerable populations. ACAP represents 59 safety net health plans in 24 states that serve almost 12 million members, which is more than 1/2 of the individuals enrolled in Medicaid-focused health plans nationally. The ACAP member health plans work with community partners to provide high-quality integrated care. We do have some great speakers for the webinar today. The speakers include Barbara DiPietro, who's Director of Policy at the National Healthcare for the Homeless Council, our co-sponsor for the webinar. Erin Hafer, Director for New Programs, Integration and Network Development at Community Health Plan of Washington, an ACAP Health Plan member. John Gilver, Program Manager, Mobile Medical Program and High-Risk Populations Planning, Public Health in Seattle and King County, Washington. And Rhonda Hoff, the COO, Deputy CEO of the Yakima Neighborhood Health Services in Yakima, Washington. We also have Rebecca Thorsness from ACAP, who's manning the controls today. I do want to mention to everyone on the line that the webinar is being recorded. During the call, all the lines will remain muted. However, we still encourage you to ask questions. You can do that by typing your question in the box to the right of your screen and then just hit send. We will have a question and answer session following all the presentations. So at this time, I will now turn the call over to Barbara DiPietro, Director of Policy at the National Healthcare for the Homeless Council. Barbara?
Thanks very much. I really appreciate folks coming out today to talk to us about the exciting partnerships going on in Washington State. If I can get the next slide, great. Just a little bit about Healthcare for the Homeless Council. The council provides training and technical assistance, research, policy analysis, and advocacy in support of HCH grantees and other homeless healthcare providers. Most people are familiar with federally qualified health centers. HCHs are a special populations type of health center. So most Healthcare for the Homeless are FQHCs. FQHCs, about 1,200 health centers nationally, saw over 1 million homeless patients were documented in 2013. And so of the 1,200 health centers nationally, about 250 are Healthcare for the Homeless projects. And those projects saw the overwhelming number of homeless patients that do receive their care at health centers. So you can see that HCH really does provide a disproportionate care, which is really why we're trying to focus on how can we bolster the HCH relationships with their managed care organizations. The services that Healthcare for the Homeless provides are the same that you would expect at any FQHC with a focus on primary care, but with a bit of a difference in that Healthcare for the Homeless are required to also offer substance abuse services. And in addition, many of the grantees also have integrated mental health. So you'll see a broad range of care from primary care, integrated behavioral health, and then of course outreach, enrollment benefits, and many of the other support services that you would expect at an HCH, or rather at an FQHC, but then in particular for a Healthcare for the Homeless grantee where you've got clients who have more intensive needs. And specifically, one of those things that we do find more and more permanent supportive housing programs are either in conjunction with healthcare for the homeless or in some way affiliated with a community relationship where you'll see a lot of continuity of care between those types of care arrangements. The clients that we tend to see differ from regular health center clients in that many of the folks that we see have very high rates of chronic and acute disease. Typically, we don't see someone who has one diagnosis. Our clients tend to have 5, 10, 15, and 20 diagnoses, and so tend to be coupled both acute and primary care conditions, but then also coupled with significant behavioral health conditions, and whether that's addiction or mental health or a combination. You'll see a lot of co-occurring disorders, which makes the care that they need particularly complex to manage. And so for this reason, you'll see a lot of intensive care case management and care coordination needs, and then the services that are trying to be matched to those needs within an HCH environment. Now, what's really changed, and I think what's really precipitated some of the relationships and some of the conversations that are happening at the local level, and what's then precipitated this call and really trying to promote more of these conversations, is that prior to January of 2014, the majority of the people receiving care at HCH were uninsured. Typically, clients did not qualify for categorical Medicaid eligibility. That changed, of course, in states that expanded Medicaid under the Affordable Care Act, and in those states, we're seeing tremendous increases in the numbers of clients experiencing homelessness who are now enrolled in Medicaid and are now having a managed care organization be a part of their life as well. And so what we're hoping is to try to increase the amount of knowledge, of the appreciation of the level of service intensity that's needed to manage the care for people who are newly enrolled. And for some of these folks, it's the first time that they've ever had insurance. And so it may be that there's an unfamiliarity with how you use insurance or how you not only gain coverage, but then retain coverage. So these are some of the issues that we're really looking at now. But then also, how is it that as care providers, we're able to best partner with managed care organizations, because really we've got more people who are now engaged in the care responsibilities for some pretty vulnerable people. And so I think we're really just trying to build a bridge of communication and learning so that we can see how is it that we can support these clients to the best of our ability, given that we all have a lot of vested interests and goals to really see that these patients are met with the needs that we're able to provide the care that these patients need, as well as really partner well to make sure that we're maximizing all the limited resources that we know that we all have. And so with that in mind, just as a kind of an introduction really to some of the issues and some of the patients that we're seeing, just wanted to say thank you for coming together, and I'll turn it over to Erin, who will talk a little bit about what's going on in Washington. Thank you.
Thank you, Barbara. Go ahead.
Thank you. Go ahead.
Hi, this is Erin Hafer with Community Health Plan of Washington, and thank you, Barbara and Deborah, for the introduction. Today I'm planning to highlight Community Health Plans of Washington's collaboration with 2 healthcare for the homeless sites, Public Health of Seattle and King County, and Yakima Neighborhood Health Services in our implementation of the Mental Health Integration Program. Just for some quick background on Community Health Plan of Washington, as Deborah mentioned, we are an ACAP plan. We were formed in 1992 by the community and migrant health centers throughout Washington state, and currently have 21 member community health centers that participate in our governance, and also our primary network for the services that we provide in Washington state. Community Health Plan of Washington is unique in that we are the only non-for-profit health plan serving the Medicaid population in Washington state. There are 5 other health plans that are for-profit serving the Medicaid population in Washington state. So this really, our founding by the community health centers really translates into our core belief that increasing access to healthcare services really translates into healthy families and strong communities. We serve not only the Medicaid population, but we also have Medicare Advantage products, and are also offering product through the Health Benefit Exchange, and we serve more than 340,000 individuals across Washington State and have a history of operating in all 39 counties in Washington. As Barbara mentioned, we've also seen an increase in our Medicaid membership through that newly eligible Medicaid population. So since January of last year, we've grown by over 60,000 enrollees of the newly eligible Medicaid population. Next slide, please. So in terms of our service delivery system, in addition to having the 21 community health centers, which operates in more than 122 clinic sites across Washington, we also contract with what we call affiliate providers that operate out of 501 sites across the state, and that totals to 623 primary care clinics and 2,500 primary care providers. We're also contracted with a wide range of specialists and all of the hospitals in Washington State. In addition to that, we have a growing number of community-based organizations that we contract with to really focus on outreach and engagement of our Medicaid population, which includes programs like our Health Homes program and our Transitional Care Services program. In addition to these sites, many of our community health centers have also been expanding their delivery systems, building new clinics to address the new Medicaid population and service demands that have come with healthcare reforms. Next slide, please. So today I'm highlighting our mental health integration program, which was started back in 2007, and it was really designed to focus on a specific population, the Disability Lifeline population, also known as the General Assistance Unemployable population. So this was a population who's deemed incapacitated for 90 days or longer due to physical or mental health incapacity. And as you can see from this Venn diagram, in Washington State, the Disability Lifeline population has quite an array of co-occurring diagnoses, including 71% experiencing chronic physical illness, 66% experiencing mental illness, 38% experiencing substance use disorder, and 26% having all three of those conditions occurring at the same time. In addition to those diagnoses, the population also has a high prevalence of housing instability, with 23% experiencing homelessness. There's also about 23% of the population who have had recent criminal justice involvement. So quite a complex population that we were working with to design the mental health integration program. And while this population wasn't strictly homeless, we have seen many good outcomes for the population as a whole, and specifically good outcomes for those individuals within the population who are experiencing homelessness. Next slide, please. The mental health integration program is designed to be a stepped care program that really emphasizes integrating mental health services into the primary care clinic, but also includes mental health services when indicated, so referral to specialty mental health when indicated. If you go to the next slide, this just highlights that our mental health integration program is built off of the evidence-based collaborative care model, which is a well-known model for integrating physical and behavioral health services in the primary care clinic. More than 70 randomized control trials have shown that collaborative care can be effective for common mental health disorders such as depression, and is more cost-effective than usual care across diverse practice settings and patient populations. We've also seen through our experience with the mental health integration program that we're able to treat not just mild to moderate mental health conditions like depression, but we've been able to effectively treat more complex conditions such as PTSD and bipolar disorder. Next slide, please. So the general principles of our MHIP model or collaborative care are that really there should be a patient centered care team. So members of the care team collaborate as an integrated care team. So the behavioral health provider, rather than just being co-located, is actually effectively operating as a member of the care team along with the PCP and consulting specialists. Care should also be population-based in that the care team is looking at the entire caseload of patients and managing them through a registry to ensure that no one falls through the cracks. Additionally, care should be measurement-based and focused on treatment to target. So that if someone's not improving, we're measuring that and making treatment adjustments as needed. Also, care should be evidence-based in that evidence-based care modalities such as motivational interviewing, et cetera, are used. And also, care should be accountable in that providers are held accountable for reimbursement based on quality outcomes. If you go to the next slide, this really highlights specifically what's unique about the mental health integration program and how we've implemented it in Washington State. So as the managed care entity, Community Health Plan of Washington funds a mental health care coordinator who's embedded in the primary care team. So what we do is we grant funding to our community health centers to hire that mental health care coordinator who's then a member of the primary care team in that clinic. The care coordinator actively manages a caseload of patients, which is supported through the use of a web-based registry to track outcomes over time. And the outcomes that we're tracking in this case is we're using standardized depression screening tools like the PHQ-9 and the GAD for anxiety, not only at initial screening, but also as a tracking tool over time to see whether someone's actually improving or whether their condition is staying the same. On a weekly basis, the care coordinator consults with a consulting psychiatrist. This role of the consulting psychiatrist is also funded by Community Health Plan of Washington via a contract with the University of Washington Department of Psychiatry. So on a weekly basis, the care coordinator reviews his or her caseload with the consulting psychiatrist, focusing in on individuals who aren't improving and making treatment adjustments as needed. In addition to those screening tools, we also have real-time tracking of quality aims, which are pay-for-performance incentives that are used for the care coordinators as well. So the funding for the care coordinator is contingent on meeting those quality aims, which include measurements around follow-up contact, measurements around consulting with a psychiatrist when patients aren't improving, and also clinical improvement measures such as improvement in the PHQ-9 score for depression or the GAD for anxiety, or also improvement in achieving care plan goals as measured through our registry. The next slide highlights a visual of this model just so that you can see how this works in practice. Above the two dotted lines are the resources that are in the primary care clinic. And as you see in the purple oval, the behavioral health care coordinator and the consulting psychiatrist are the new resources to the care team that we've focused on funding through the mental health integration program. As you can see from this diagram, the behavioral health care coordinator consults with the consulting psychiatrist who's remotely available to the consulting psychiatrist, and then any recommendations that come out of that consult are given to the PCP. In addition to coordinating with the PCP, the patient, and the consulting psychiatrist, the behavioral health care coordinator works with other members of the care team, and then also with key community partners like chemical dependency treatment agencies, housing providers, and specialty mental health, among other things as needed. Next slide, please. So initially, our program started out as a 2-county pilot in 2007. It was then expanded statewide in 2009, and we've gradually been expanding it to other populations. Today, you can see an indication of the various locations of the behavioral health care coordinators participating in the mental health integration program. And to date, we've served over 45,000 patients in over 100 clinics in Washington State. Next slide, please. In terms of the trends that we've seen in outcomes, for that initial 2-county pilot, which was specific to the Disability Lifeline population, so again, that population that we saw the Venn diagram of earlier, what we experienced was a reduction in inpatient admissions, smaller increases in inpatient psychiatric costs, and then relevant for this particular webinar, lower increases in homelessness in clients receiving services through the Mental Health Integration Program, as well as reduced arrest rates in clients receiving MHIP services. Also, in our expansion across the state, we were able to demonstrate hospital savings of over $11.2 million in the initial 14 months of the statewide expansion. And through our pay-for-performance initiative that rolled out, we did a study where we found that prior to rolling out the quality aims and after rolling out the quality aims, we saw the time to improvement in depression score cut in half. So after focusing in on those quality aims, people would get better 2 times faster. Next slide, please. So in terms of what we've been doing with the program over the last several years, we've been working on expanding the model. And through a close partnership with Public Health of Seattle and King County, we've been able to leverage local sales tax dollars to expand the model to additional populations and additional service locations. So we've expanded the model to include Medicaid enrollees with special health care needs. So those are individuals who have 2 or more chronic conditions and are at high risk of hospitalization. We've also expanded the model to include health home enrollees through our state's health home program, as well as uninsured individuals via the local sales tax dollars in King County, and to the mobile medical program patients, which John Gilvar will be mentioning shortly. And we've also piloted the same model with medical respite patients here in Seattle as well. I think one of the important pieces to mention here is that these expansions have been very helpful in engaging our members who may not already be engaged in the primary care clinic, but maybe some of our providers are able to engage, but then make that warm handoff back to the behavioral health care coordinator at the primary care clinic, thus improving the follow-up rate. Also, what we've seen is that this model can be very scalable for complex populations and at various service locations, and you'll see that in some of the presentation that John and Rhonda will give shortly. Thank you.
Erin, thank you very much. Now we're going to hear from John Gilvar, the Program Manager for Mobile Medical Program and High-Risk Populations Planning, Public Health, Seattle and King County, Washington. John?
Great. Thank you very much, and thank you, Erin. As was just said, I manage the mobile medical program for public health in Seattle and King County, and we think of that program as the safety net or a safety net below the safety net in our community. So our hub for our services is the 38-foot RV that you're looking at in this slide, which is equipped as a medical and behavioral health clinic. And as you'll see in the upcoming slides, our clients are at very high risk for bad health outcomes, hospitalization, and premature death. So what we know is, can I just interrupt a second? I'll ask for the slides to be advanced when we're ready. They seem to be advancing. Thank you. What we see is that even though King County has a very well-developed community healthcare system, the clients that are in our target population, the people in our target population, are kind of routinely falling through that safety net, and that we're catching them with this program. And what we'll talk about today is how 6 years ago, when we were in our first year of operation, we partnered with the MHIP program, the Mental Health Integration Program that Erin described, after our clinical team found that almost none of the clients whom it referred to mental health providers were accessing treatment from those providers. Okay, next, please. So I'll give you a little bit of operational background here. Okay, can you go back one, please? We park our medical van at community lunches and dinners that attract large numbers of people who are living homeless, about 700 people last year, a little bit more than that the year before. We park the medical van that you saw in the last slide at community lunches and dinners, mostly at churches, that attract large numbers of people who are living homeless. And about a third of the time, we also bring a dental van that we park next to the medical van, and clients check in and do intake at the medical van and then can access dental services as well. So our program is funded partially through a federal Healthcare for the Homeless grant and also a local public initiative that is designed to improve access to physical and mental health care and behavioral health care services for people who are living homeless and also veterans. It's called the Veterans and Human Services Levy. So the decisions about where we bring our services are driven by research indicating where we can serve and find and serve the greatest number of people who are living homeless. And you would think that sometimes when you think about the suburbs, you don't think of large numbers of homeless people, but in these suburban cities, these cities represent the areas of King County that experience the highest rates of poverty and the worst health outcomes. Okay, next slide, please. So our clients are living unsheltered. They're doubled up, which means just living in apartments or other housing that's intended for a much smaller number of people than are actually living there. They're couch surfing. They're living in shelters. Sometimes they've moved into housing that is designed for people who've been homeless. And typically they're moving from one of these situations to another situation. So it's very kind of an unstable situation. Okay, next please. So these are some of the characteristics of our population. About 1/2 of our clients experience chronic mental health disorders. They're often disconnected from treatment. We see a lot of substance use disorders. We have a lot of people that have cognitive impairment. Some have traumatic brain injury. Some have impairment that's due to long-term substance use. Our population has frequent misdemeanor arrests. And then I would say the most common denominator for our clients, because it's really hard to generalize about the causes of homelessness and the characteristics of homelessness, but one of the things that's really common in our population and among our clients is an absence of family and other social supports. Okay, next please. So for our one back please. So for our clients, the impediments to chronic disease self-management, you can see there's this sort of constellation of issues. This isn't exhaustive by any means, but as I said, a lot of untreated mental health and substance use issues, very low or non-existent income, no consistent relationship with a primary care provider and using the ER a lot for primary care. Survival needs are usually prioritized above long-term health needs. There's a lot of violence that's experienced by this population. There's domestic violence. There's just people are just attacked. They're living in the woods or on the streets, et cetera. And there's a lack of transportation. Next, please. So our front door to services, and this is really where we'll get into our model here, is walk-up access to physician, dentist, social worker, nurse, chemical dependency professional, and medical benefits access and navigator services. So I'm going to pause here for a second because I'm going to get into the nuts and bolts of the way that our program works on the ground. But I kind of want to take a second to talk about our population from a public health perspective. Because when you kind of start to look at some of the factors we've looked at in the last couple of slides, people living outside, moving around a lot, high incidence of untreated mental health and substance use disorders, they often have, our clients often live from one crisis to the next, including arrests and victimization from violence, injury, et cetera. All of those types of factors mean that our clients are frequently the square pegs that don't fit into the round holes of more typical chronic disease management methods. So what we see is they can be difficult to find. They can be difficult to routinely reach by phone or mail or email. They often miss appointments that are office-based appointments. They can be very distrustful of the healthcare system, whether it's the VA or community health centers or community mental health centers, often because of past challenges they've had in accessing care. And they sometimes see the ER as the best avenue for treatment. So what we're seeing is, with this population from a public health point of view, is that the same issues that make these clients quote-unquote difficult for primary care providers, community mental health providers, those same factors, those same challenges are exactly the ones that drive up their risk for hospitalization and their risk for readmission after hospital discharge and their long-term poor health outcomes. So really what we've got is kind of a classic catch-22. So the folks that in the community, many of the folks who have the highest risk factors, we have lots of clients with, say, comorbid, COPD, schizophrenia, substance use disorders. That would just be one example of a kind of a constellation there. Those clients are the ones that are least likely to be reached by and engaged by systems that are usually more office-based, that are designed to improve chronic disease management, but they sort of depend on a connection happening in an office, or they depend on being able to routinely reach somebody either in their house or by phone, for example. So an example of what we see as a result of that challenge is that our physicians will often see people that when they come into the medical van, their conditions, their symptoms are already at a very acute state where you really kind of wonder how that person was able to just get through their daily lives with a situation like that. So an example would be a gentleman recently who was in his early 60s with COPD and a very debilitating crack addiction, who was helped by our chemical dependency professional to access a bed in a shelter. And then our chemical dependency professional, got a call a day later from the client saying, he just really was having trouble breathing in the shelter and getting around the shelter. She helped arrange for him to be seen at a community health center nearby the shelter. He was immediately sent to the ER, and from the ER he was immediately admitted into intensive care and is just now, I think, being released from intensive care. So his breathing, he was kind of walking around, completely unsheltered when he came to us, and 2 days later he's in intensive care. Next slide, please. So what we've done over the 6 or so years since we started the program is we've evolved our staff and increased our sort of capacity to work with different challenges based on the needs assessment that we do with each client that comes into our system. So this is in the first year. You can see here some of the most common needs that we were able to identify with that need screening. And you can see at the bottom, in the first year, almost 80% of our clients said that really didn't have regular primary care access. Next slide, please. So our special sauce, so to speak, is we provide respectful and flexible outreach and engagement. We have a team-based approach. We really take advantage of the fact that we are bringing our services directly to where clients already are, that we're not requiring them to come to an office. A lot of our clients routinely eat at the same community meals week after week, and to some extent they organize their lives around where they're going to eat on a routine basis, where they can access food. So we're going to them and we're offering our services, a whole array of services, whether it be physician services, dentist services, social work, we're offering that on a walk-in basis. So our outreach is basically just helping people find our services, and we're allowing people to access the services that they want. So it's driven by, it's very patient-centered, it's driven by what the client wants. And as I'm going to talk about in a minute, we've added, through a partnership with MHIP, we've added a clinical assessment for behavioral health needs that happens in the field rather than requiring the client to reach an office to start basically the process of accessing mental health care and behavioral health care in general. And also we do warm handoffs among a whole team of people that provide this outreach and clinical treatment. Okay, next. So we're providing what we feel like is a transitional medical home. In some ways, we feel like this is like close to some of the aspects of a health home as the Affordable Care Act defined it. We're closely tracking linkages that we make to the community health centers that are nearby our service sites. And we're providing a lot of care coordination between our mobile medical clinical team and the clinicians within the community health centers. And then for some clients, they're just not ready to go to the community health centers, and we're functioning as their home clinic for some period of time. It's been extremely important that we've been able to partner with a community health center that has primary care clinics that are spread throughout the area of the county, a wide swath of the county where we provide our services. If you go to the next slide, you can see sort of the overlap. So the triangles are, the orange triangles are where we have, this is at least part of our service area, where we have our clinic sites at the community meal programs, and then those sort of turquoise diamonds are the Health Point Community Health Center primary care sites. So generally speaking, at the sites that we serve clients, there's a nearby health center site. Okay, next please. So we've adapted the mental health modality into also our population of people. How that came about was when we first started out in the first year, we were referring clients with physical health, like chronic conditions, diabetes, hypertension, et cetera, to the Health Point Community Health Centers. But for people with mental health conditions, we were referring to the local community mental health center. And the second avenue just didn't work. Our clients were not, you'll see in a future slide, in one of the slides that's coming up here, you'll see that our clients just were not accessing care within the community mental health center system. And so we thought about, public health, where I work, already had a strong relationship with Community Health Plan of Washington and the UW Psychiatry School, which, they're developing the MHIP program. So we met with Aaron and we met with a psychiatrist at UW, and we said, okay, how can we adapt the MHIP model that really was developed for a fixed site, primary care site, where clients are coming back in for services? How can we adapt it for our mobile situation? And so the first thing we started with was hiring with federal grant money MSWs that have real behavioral health experience. We are doing the assessment and the follow-up with the tools that MHIP has, and we're tracking clients using their the MHIP system. And then we're handing off clients, when the clients are ready, to a PCP or a mental health care coordinator at the community health center. We're taking advantage of the psychiatric consultation that Aaron talked about. We're doing case conferencing with our team so that the physician and the nurse and our social workers and our chemical dependency professional are all on the same page about where the client is in linking to treatment. And we're catching the failed linkages. So we often, again, see the same clients at meal programs, and we check in with those clients. Did they make it to the community health center for treatment, or do we need to try again? Next slide, please. So this is sort of our pre-MHIP status quo. This was in the first 6 months of our program's operation, where we were tracking the completion rate of clients that we referred to the community mental health system. And you can see it was pretty abysmal. We had 1% of the people that we identified as having a mental health treatment need, which obviously is not all of our clients, but some of our chunk of our clients. We were referring those to outreach workers who work for the community mental health system, but for a variety of reasons, they weren't making into treatment. Okay, next slide, please. So this is our current rate of mental health assessment using the social workers who are part of our team. You'll see for 2014, this is of all clients. We served 695 clients in 2014, and 14% received an on-site assessment using the MHIP, the Mental Health Integration Program tools at our service sites. And you may think that why isn't it closer to 50%? But in reality, with our population, there's a certain percentage of clients that are only going to access our services once or twice. They may get dental care or medical care and not return. Some people have a mental health issue, but they're not ready for some period of time. Sometimes it takes years for some of our clients to be ready to actually sit down and do an assessment. Some people are reconnected with providers that they have seen in the past who, really all that's really needed is if they have a community mental health center where they've been accessing psych treatment in the past, we can reconnect them. So we feel like compared to the 1% of our clients where we've established a need who made it into the community mental health system, assessing in the field 14% is a really good start. So then the next slide, please. So this is showing the number that actually received mental health treatment at a community health center, one of the Health Point community health centers. So it's a full 20% of our, again, for our total patient population or client population for the year 2014. So a good percentage of those people we feel have an unmet treatment need. One of the keys that kind of a critical decision we made that I think has really helped this success rate is as we were working with Aaron and Community Health Plan of Washington and UW to adapt the mental health integration program, we made the decision to really double down on our partnership with Health Point, and the social workers that we brought on board, we contract with Health Point for those social workers. So they work on our team full-time. They're full-fledged members of our team working side by side with public health employed physicians, intentists, and outreach staff, nurses, et cetera. But because they have kind of one leg in our mobile medical program and one leg in the community health center, they're really able to facilitate access to community health center appointments extremely effectively. And they can often get people an appointment, especially if there's an acute need, within a day or two, which really, if the client had gone directly to that community health center, it would have been very difficult. Okay, next slide, please. I'm going to wrap up. I think I'm encroaching onto around this time. Just really quick observations here. Since the beginning of the expansion of Medicaid, where enrollment started on October 1st, 2013, we've enrolled 500, actually just over 500 clients in Medicaid managed care through the Affordable Care Act. Most of those people were not eligible before. And then, again, as I mentioned, some of our clients with mental health needs are receiving counseling and treatment from our medical van clinicians and are not ready for community health center treatment. So again, we have a very flexible patient-centered model where we're able to assess when people are ready to be referred and really become part of the mental health integration program, and when people can just be treated on the medical van. So, and the next one is just the contact information, and I will hand off from here. Thank you very much.
Thank you so much, John. So our final speaker for today is Rhonda Huff. She's COO, Deputy CEO of the Yakima Neighborhood Health Services in Yakima, Washington. Rhonda?
Thank you. So I'll go ahead and start my first slide, please. There we go. So this is our mothership. Yakima Neighborhood Health Services is a community health center. We are an FQHC. We're in central Washington State. We were established in 1975 with a mission of providing comprehensive health care for low-income residents in the Yakima Valley. We're about 2.5 hours east of Seattle. Our first application for federal funding was from the Bureau of Primary Health Care, and it wasn't until 2004. And we became a Health Care for the Homeless grantee. Over the last few years, our board of directors expanded our organization's mission to reflect the additional efforts of housing and social service assistance that we've added to support the needs of the homeless individuals and families. Next slide. Services that we've added as the demand warranted and as the community requested. Our homeless patients represent just about 12% of our total patient population. The additional services that we've added over the last few years specifically target homeless populations, and we do provide things like permanent supportive housing, transitional housing, medical respite care, and basic needs assistance. Things like we have an equality fund that helps pay for school activities, music lessons, a camp for kids, help with hygiene kits, bus passes, tuition for school and vocational training, and help with food and clothing. Our managed care members have been helped with things like car seats, cell phones, pedometers, and glucose monitors from their health plans. Next slide. So we see homeless at all of our 5 primary care sites. We have one dedicated Health Care for the Homeless clinic, and that's located inside a chemical dependency center. This particular clinic also faces the city transit center, and that's a real gathering place for the homeless in the Yakima. The PC clinic here on the right is located inside a community mental health center. And at this site, we have a nurse practitioner, a medical assistant, and a dietitian. The nurse care coordinator and the psychiatrist are employees of the mental health agency. In both of these sites, until implementation of the Affordable Care Act, the patients were mostly either uninsured or covered by a fee-for-service Medicaid, Medicare, or a disability program. Over the last year, we've been able to gain health coverage for most of these patients and work with them to understand the importance of primary care services. Our case managers and our care coordinators have been essential in helping patients understand how the managed care system works. Our patient navigators worked hard to gain coverage for our uninsured. With the dramatic change in health coverage among our homeless populations particularly, we also needed to work with our patients to understand how to ask the right questions when selecting a managed care plan that was right for them. First, what plans their provider was contracted with, and what specialists they were using, or if they were connected to a specialist, and what plan their specialists were connected to. And then other considerations, things like if they had transportation or needed transportation, if there were language needs, and if there were any ADA needs that needed to be considered for the providers that they were seeing. Next slide. So John talked about this a little, but truly from our perspective as well. As a Health Care for the Homeless provider, our case management model is based on best practices of trauma-informed care and self-sufficiency assessments. We meet many of our patients with backgrounds of homelessness, human trafficking, and forms of victimization from families, from friends, as well as from strangers. And in a managed care world, oftentimes these patients get labeled quickly as being non-compliant, antisocial. But if we wrap the right wraparound services around them, then we see great improvements in their health outcomes. And in our community health center, their outcomes are very often comparable to our general population. Next slide. So last year, our homeless patients access primary care services at a higher rate than our general population in all service areas that we offered. And a big factor of that was the case management services and the other services that we offered to help them get to the care that they needed. We were really actually surprised when we first really ventured into healthcare for the homeless, because we thought, because we were a community health center, that if homeless patients had needs, that they would come to us. And so for some of the things that John described earlier, I have to really agree that we really had to beef up a lot of our outreach services and enabling services to go find those folks that weren't coming to us. We had to do a lot of trust building and reaching out to them first in order to get them to access care. And we have a much stronger relationships with them now than we ever have before. There were also increases in services from the previous year when we had higher rates of uninsured. So it was much more than just access to health insurance that really helped us increase our continuity of care with our patients. Next slide. Our most common chronic problems among homeless adults are not wildly different than our general population. They just tend to have more of them. Our biggest advantage here is, again, the strong enabling services support that we have for our patients. We have multiple contacts a month to support and reinforce their health issues through our outreach team of nurses and case managers in the field. Particularly with clients in supportive housing, we see these patients multiple times a month and have the ability to help them support their self-management goals, provide patient education, and connect them to ancillary providers like dietitians on a regular basis. The bench strength of our healthcare team is one factor that's helped us achieve NCQA Level 3 patient-centered medical home recognition for our sites. And Neighborhood Connections, the homeless clinic, was one of our first sites that was recognized back in 2011. Next slide. The Community Health Plan has also helped us with several programs that focus on healthy children. And these could be particularly helpful. Some of these programs are helpful with our homeless families. We maximize these opportunities to reward healthy behaviors with items from the plan, things like children's car seats, backpacks, books, bike helmets, even gift cards are very well received, and they're great incentives for parents and children who have so little. Next slide. We also have a medical respite program. Last year, we provided over 700 bed nights to 33 homeless individuals. Most of these patients now have Medicaid coverage, and almost half of the patients in 2014 that were in respite care were covered by our state's managed care plans. Of the patients discharged to respite, either from the hospital or the same-day surgery center last year, no patient was readmitted to the hospital from our program within 30 days of discharge. Several studies have shown that the homeless patients discharged to a medical respite program experience significantly fewer hospital readmissions than homeless patients discharged to their own care. So we're currently working with the Community Health Plan and other health plans on a reimbursement structure for their members we support in our respite program. Next. The Health Home Program, the ESHN program, and Medical Care Services programs are all different models of care coordination and integrated health for high-needs patients. Several of our homeless patients are eligible for these programs through CHPW and other managed care plans. Each provides care coordination for medically fragile patients. We included our health care for the homeless staff as care coordinators in order to maintain the existing relationships for our patients who are often reluctant to let new people into their lives. Next. This is a great example of a patient who qualified for ESHN, or the Enrollees with Special Health Care Needs program. This patient had many more needs than our primary care provider could take on in the exam room. This particular patient, a managed care member, was chronically homeless. She's a former heroin addict and was in the local methadone program. She was a cancer patient. She was living on the streets and referred to us by the Cancer Treatment Center. We placed her in our medical respite program last summer. She was there for about 30 days. and then we transferred her into a permanent supportive housing unit. She receives regular checks now from a nurse, behavioral health specialist, and her housing case manager. The nurse is actually her care coordinator. And she's actively engaged now in her physical health, behavioral health, and dental care. She hasn't been to the hospital or to jail for over a year. Next. In our center, we have 2 dedicated full-time care coordinators, and we're about to add a 3rd. In addition, 4 of our Healthcare for the Homeless staff are trained as care coordinators for the homeless patient, and you can see here who they are. Next. The Health Home program is voluntary. It's not surprising that our success rate for enrollment is greatest with the patients who have relationships with our staff. Currently, our enrollment rate with the Community Health Plan is almost twice as high as other programs who assign patients to us that we don't know. As Erin described, the plan has been responsive to us in helping to minimize barriers to specialty care, and first by providing the funding for the care coordinator so that we can hire that person to work directly and be part of our staff, and they're on site here in our center. They also contract with important providers that will be sensitive to the unique needs of our patients. And the consulting service for the psychiatrists at the University of Washington has been very valuable for our primary care providers as well as our behavioral health specialists. The Emergency Department Information Exchange, the EDI program, is also a tool that our providers use quite a bit that gives them information about how often or when patients are using the emergency room. Next. I think you've heard both from Erin and from John about the quality aims through the MHIP program. From May of 2009 through January, we've enrolled over 500 patients through the care coordination programs here in Yakima. About a third of those patients that we've seen have been homeless, either literally homeless in shelters, living in motels, or with families and friends. Of the 218 who had both a baseline and a follow-up PHQ-9, 41% have shown an improvement of 5 points or greater between baseline and follow-up. 22 of those patients had also had a baseline and follow-up of the GAD-7 screen, or the anxiety screen, and half of those, 50%, have achieved a 5-point or greater improvement. Next. So we know that the social determinants of health are more than 70% predictive of health conditions than genetic predisposition. Many healthcare for the homeless providers use tools to help their patients address those social determinants, set goals, and measure progress that ultimately will impact their overall health and the health of the family members. We use the Arizona Self-Sufficiency Matrix for both assessments and goal setting, and have incorporated this into our electronic health record so all disciplines on the team can refer to it. The Self-Sufficiency Matrix measures progress across 15 domains of patients. This aggregate report shows how our patients in supportive housing have improved their levels of self-sufficiency overall in many domains that affect improved health. Next. A few years ago, it was almost antithetical to think that managed care systems could be successful with homeless populations. We have some great success stories working with our plan and our community partners, not all of whom are clinical. A commitment to supporting traditional as well as alternative forms of case management and care coordination, contracting with community partners who serve the homeless in a coordinated fashion, and then working with providers on issues like trauma-informed care, behavioral health, primary care integration, supportive housing, and intensive care coordination are cost-effective interventions that have the potential for significant improvements for this population. Thank you.
Thank you so much, Rhonda. So at this time, we're going to have a question and answer session. As a reminder, if you would like to ask a question, please type your question in the box to the right of your screen and then just hit send. We'll try and ask it ask as many questions as we can in the time allowed. Please note on the last screen, I've included my contact information at ACAP and some links to ACAP resources, including a report that was prepared by ACAP with funds under a grant from the Samsha Harsis Center for Integrated Health Solutions on how SafetyNet Health Center working with providers in underserved areas to integrate behavioral health and primary care, and another fact sheet on how SafetyNet Health Center positively impacting social determinants of health. So, Rebecca, at this time, do we have questions, and would you like to ask the first question, Rebecca?
Yeah. We had someone submit a question about the MHIP program, and they were curious about the procedure for identifying and treating people with schizophrenia and the gravely disabled who come through the clinics in the MHIP program.
Erin?
Hi, this is Erin. So in terms of the schizophrenic population, really the method that we use there is via the consultation with the behavioral health care coordinator and through the consultation with the psychiatrist. In the case of a schizophrenic patient, what likely would happen is that might be beyond the scope of what the team within the primary care clinic could manage, but what is helpful is that there's that opportunity to discuss with the consulting psychiatrist in advance to see if there might be something that could be started, or whether a referral to a specialty mental health clinic would be necessary in that case. Typically, the way that people are being identified is via referral from the primary care provider. So the primary care provider may be screening with a PHQ-2, for example, but may identify other needs as well in the primary care visit and then refer to the behavioral health care coordinator. I'm not sure, Rhonda, if you have anything to add to that based on your experience.
I really don't.
Okay.
Okay, Rebecca, any other questions?
Yeah, someone was curious. They said that in their experience, FQHCs require patients to provide identification when registering, and oftentimes individuals experiencing homelessness have lost their belongings or they've been stolen, and so they don't have any type of ID. How have you handled this barrier?
So this is Rhonda. So we don't, I think that's an individual FQHC policy. There's no, national or federal requirement that a patient require identification, so that's going to be an individual policy. In ours, we would not turn a patient away if they didn't have identification. We do ask for it, but if somebody doesn't have it, that would not stop them from receiving care.
Thanks. So we have a few questions about how the various pieces of this program are funded, and in particular the respite care. I was hoping that you could speak a little bit more about that, Rhonda.
About how respite care is funded?
Yes.
Well, again, at this point in time, I think there's about 70, 75 respite programs around the country, and that's a real challenge because we're all funded differently. And in our particular program, we get some funding from our county that helps us with the housing component, and then we fund some of the meals component, and we fund the staffing through our Healthcare for the Homeless grant. And if you ask every different program, you're going to hear, a dozen different ways that different projects are funded. So so we are trying to identify some different, different models that we can get more strategic in looking for funding for that. But we have all talked about trying to find a more comprehensive ways to put the respite programs together, because we've shown that it's so much more cost-effective to bring people, to discharge them into a respite program than to either keep them in the hospital longer or having them come out of a hospital and go back in. So, but in our case, it's a combination of some local funds, some donations, and part of our Healthcare for the Homeless grant.
This is John. I would just add to that that in King County, there's also a respite program, and the managed care organizations, Medicaid managed care organizations, have invested in that program and supporting that program. And as well, we've worked with the state to create a billing code, a Medicaid billing code for services provided in respite care, and that's been incredibly important to the viability of the King County program.
Great, thank you. Along the same kind of funding theme, I think, Erin, you can probably answer this. The care managers in the MHIP program, I know that the managed care organization funds them. Can you talk about that more specifically?
Sure, I'd be happy to. So in terms of the way we fund the care manager, it's not on a fee-for-service basis. What we do at the health plan is we basically fund what we call a unit. So that may be equivalent to an FTE in some systems based on the number of community health plan members that are being seen at that CHC. So we fund that unit, and then a certain percentage of that annual funding for that unit is tied to achieving the quality aims, so those pay-for-performance requirements. So Rhonda highlighted some of those in terms of the achievement in improvement in the PHQ-9 score as well as the GAD score. And I wanted to highlight, too, I think Rhonda showed that those improvement scores were around 40% achieving a 5-point improvement in PHQ-9 score. And what we see in usual care is that really there's only a 20% improvement if someone's just receiving treatment as usual and not in this collaborative care type way with the role of the consulting psychiatrist working with the behavioral health care coordinator. So I think that's an especially powerful statistic, especially when you consider that a third of the patients were experiencing homeless or housing instability. We've been able to continue supporting the care coordinator funding as well as the consulting psychiatry funding because we've seen a tremendous ROI, return on investment, for the program. We have been working closely, though, with the state to develop more sustainable mechanisms so that services like consulting psychiatry could be, for example, a billable service, or there could be better methods so that this funding mechanism could be used across all payer types, not just via community health plan.
Thank you. To the people who are asking, ACAP will post the recording for this webinar on our website in a few days, and that's communityplans.net. And we can send an email out to everyone who's attended the webinar as well with a link to the slides and recording. I have a question for John. Do you have community health education programs in place for the homeless population you are serving?
Community health education programs. Well, I mean, you could say that a lot of what we do in the mobile medical program it would come under that rubric. Our whole model is based on engagement, outreach and engagement, trust building. We do a lot of work with motivational interviewing and harm reduction, and over time we're doing a lot of education about how people can access community health resources. We have a dedicated medical benefits specialist who helps people enroll in Medicaid, and again, we're referring people into the community health center system all the time. So there's a big education component to that. I'm not sure if that answers the question, but that's what I would say.
Great, thank you. So we have a number of questions just kind of about the specifics of funding and setting this up, but I think more generally, since we have people from all over the country on this, I would hope that the speakers could kind of just give some general advice for how do health plans go about connecting with homeless providers, and how do providers go about working with their MCO partners and state partners. And so I was just, if all of the speakers could just speak a little bit on that for other people who are trying to get similar programs started.
Sure, this is Erin. I'll go ahead and start. And I think, one of the things that we as a community-based health plan recognize, and I think that more and more managed care plans, even the for-profit and commercial health plans are starting to recognize, is really the important role that social determinants play in overall health care and health outcomes. And specifically, homelessness or housing instability and the role that that plays as well. Really, I think that there's that good business case to be made around the return on investment, as if we have these robust strategies to address those social determinants of health, like the programs that Rhonda and John have highlighted with these wraparound services that really recognize the impact of those social determinants, we will see the savings on the back end. So I think there's a strong business case to be made in approaching managed care organizations around hospital savings, reduction in readmissions or emergency department utilization that could be made through a partnership such as these ones.
This is Rhonda. One of the things that we really appreciated when programs like the Health Home and the ESHN program started was the plan came to to us as the healthcare home the healthcare for the homeless provider. They came to us first and recognizing that this was a special needs population, and they said, who else do you need at the table? Who do we need to bring into the network? And that was really important because whether it was particular chemical dependency providers, the mental health agency, because when there are many to choose from, you can't just pick any provider when you're serving this population. You have to have providers that will be sensitive to the needs of the population you're working with. And so that was very helpful to be able to bring the right people to the table that are going to serve the population. So I guess I would say reach out to whichever direction you're reaching between the primary care provider and the plans is make sure that you sit down and talk about who are the players that aren't at the table that we need in this network, so that we have the pieces to serve the population, and pay particular attention to those non-clinical services, because oftentimes the primary care provider in some cases is kind of the smallest part of the pie. No offense to any primary care providers on the phone.
So this is John. What I would stress is that the success of these programs is really dependent on partnerships and on blending funding streams. So, for instance, with the development of the mental health integration project in King County, not only did Community Health Plan of Washington contribute greatly, but the King County Veterans and Human Services levy and the mental illness and drug dependency sales tax were really used effectively, leveraged with each other to make sure that the program was extended to populations who are not covered by Medicaid managed care. And at the beginning of our mobile medical program, that included the vast majority of our clients. It's only in the last year with the Affordable Care Act that we've seen our Medicaid enrollment really get up into the majority of our clients. In years past, it was just a sliver. So it really is all about partnerships, and sometimes that means that things get very complex. I mean, that's part of, for people on the line, they may get a sense of how complex these partnerships can become, but I think it's in this case, it's resulted in some really good outcomes.
Great. Rebecca, any more questions?
I think that we've covered the general themes of what people have been asking.
Okay, great. So thank you very much for your help with the questions, Rebecca. And so in closing, I want to again thank all our speakers today for not only a very informative but a very important call. We hope that everyone on the call today in the webinar found that the information was as worthwhile as we did. And I want to wish everyone a pleasant afternoon and say thank you and goodbye. Thank you, everyone.